All right, well, good morning and welcome everyone to the DSM Forward Ask the Expert series. The series is presented by the Greater Des Moines Partnership and it's part of our DSM Forward initiative. And our goal with this series is to help business leaders connect, share information, exchange ideas and resources related to moving forward in this next phase of reopening. The partnerships published industry playbooks, business playbooks, FAQs, and other resources available to you on dsmpartnership.com/DSM forward, as you see on your screen in front of you. We hope that these sessions are helpful to you, and take a look at our calendar for future sessions coming up. I'd like to welcome my three distinguished guests today. Dr. Eugenio Carion, Chief Medical Officer of Mercy One Des Moines, Dr. Clint Hawthorne, Medical Director, Unity Point Des Moines Emergency Services, and Dr. Yogesh Shah, Chief Medical Officer of Broadlawns Medical Center. Gentlemen, thank you all for being with us. And so with that, I'm going to ask the audience, if you would, make sure your microphones are muted. If you wouldn't mind turning off your video, you're welcome to. And open the chat window for us. We're going to be using the chat window today for any questions that come up. I've got a couple. We're going to ask the doctors to give us kind of some opening remarks, and then we'll go into Q&A. We'll try to keep this as interactive as possible. So with that, I'm going to stop sharing my screen. And Dr. Shaw, if you can kick us off, maybe give us just a few minutes overview of where you see things related to getting back into the workplace.
Sure. No, thank you, Mike. Good morning to all. Thank you to the Greater Des Moines Partnership for arranging this educational, informative Zoom. As we all hear about COVID and the new norm, the question comes up both in the healthcare system and in the business community. What is going to be the new norm and how do we live with the new norm? So let me quickly broadly share some of my views, and then we can have good discussion about it. So one is that every intervention, what we do in healthcare or from business point of view, there is potential for some harm, even though it might be well-meaning intention. Meaning, if we all decide to wash our hands every few hours, few minutes after every contact, there's a potential for that hand and skin to get eczema. Just a simple example. So what that translate into business would be all interaction as we open up our businesses. We'll have to keep that in mind, that to some kind of side effects, bad effects can happen. So that's one. Second, the test results by itself doesn't mean infectivity, and vice versa. That as we start doing more and more tests, which we are, we will see more IO1s coming as positive, that not necessarily that they are all infecting or infected. And other thing is true that all patients who are COVID positive and maybe infecting others are not going to be tested. So we'll have to keep that in mind for all our healthcare systems and for businesses as we move forward. The third is that the infection rate would vary, and unfortunately, there's still significant false negative rates, meaning if I say, hey, Mike, I'm negative, that doesn't mean that I'm negative today. I might be negative yesterday. It might be false test. It might be false procedure, but today I might be positive. So as you open up the businesses, you know, to keep in mind what is our criteria to consider as somebody is COVID positive or not. And as we have learned about the disease, the symptoms will change and vary. Initially, in early February, early March, we came up with 3 symptoms: fever, cough, respiratory symptoms. And then now we have 8, and slowly, what about the pink eye? What about blue toes? So all as we understand the disease and we correlate that with other coronavirus, that's going to continue to happen. So lot to keep that in mind. And I'll end with the last saying, Mike, that we all have our inborn biases about this disease, the source of knowledge we have, the place of knowledge we have, what we believe, what we don't agree on. So that is a huge factor on our outcomes. So I'll stop there.
Thank you. Dr. Othward, maybe you could give us some of your thoughts.
Yeah, very well put. And I like the idea that, Dr. Shaw, that you are emphasizing the fact that a lot of the information that we are receiving from the CDC and some of these guidelines, everything needs to be put into the context of a particular person, whether that be an employee or whether that be a patient. And so I'm trying to think about this from the perspective of a business owner and what that would mean for me if I were looking at reopening my business, and how do I bring employees back safely into that space, or do I bring them back into that space? And so I think what as we discuss things and answer questions and you're sorting through a lot of the details, I would emphasize that we all go back to the things that kind of prioritize things by simplest to complex, and along that same list of priorities, oftentimes the things that are the simplest are oftentimes actually some of the more effective things. And so as the complexity of the intervention grows, you'll sometimes see that the effectiveness of that intervention has fewer and fewer benefits. And so really, as you're focusing your efforts on things, and we'll talk about a number of different interventions, I'm sure, along the way, you probably want to take the majority of your effort and focus them on the low-hanging fruit that are simple, easy, going to have the highest compliance, and therefore actually are going to have the highest effectiveness.
All right, thank you. Dr. Carion, would you like to give us a couple of thoughts before we start the Q&A?
Yeah, thank you for that, Mike. And I would like to echo what Dr. Shaw has stated in regards to sorry about that. Did I freeze there?
Nope, you're doing great.
Okay. Echo, just thank you for having us, and the ability to give this brief presentation just on potentially bringing back the workforce, because I do think we all are cognizant of the economic impact that's impacted every small business to large business across the country, not just in Iowa. And we understand even although certain workforces have been able to function independently away from the normal brick and mortar kind of buildings, how long is that sustainable? One of the common things you may have seen is we've kind of changed the nomenclature from social distancing to physical distancing, because just as the human component of us requires some degree of socialization, words do matter. And so physical distancing has been the more kind of adopted terminology around that, because somehow we still have to create those social environments, whether again, that's in a virtual model or in other facets of our healthcare force. Now, the good things are we are seeing a trend down of decrease within the state of Iowa as far as the number of positives that we're getting. We still unfortunately are in a higher state in Polk County than we would like to be. But again, everything is trending in the right direction, and we're hopeful. I think this is one of the reassuring things, is that when we look across the country at healthcare workers and how many are getting infected with COVID-19, it's a fairly small number when you look at that. So that suggests if you institute the right processes, hand hygiene, physical distancing, face shields or face mask, that the likelihood of transmission can be significantly minimized, again, as long as you institute the right processes. And I suspect that's why we're here this morning. So thank you.
All right, well, we have several questions in the chat room already. Dr. Hawthorne, I think I'm going to ask you to take the first one. Can you talk about the hypercoagulability? Oh boy, I'm not good at this issue COVID-19 patients seem to have, and many succumb to. How do you manage that patient at the point of urgent care and the point of inpatient and ICU management? I don't know how much this is about the workforce, but I'm interested to hear what you have to say.
Yeah, I'll just cover some of the basics. This is a topic that is really changing rather quickly. And my internal medicine colleagues and my ICU colleagues would probably be able to give an even more in-depth answer. But the gist of it is that yes, COVID-19 predisposes you to a hypercoagulable state. That just means you're more likely to form blood clots. more likely to form large blood clots, also more likely to form very small blood clots in the capillaries. And we can see this on some of our blood tests that we'll order in the emergency department, for example. And that does predispose some patients to other diseases. So blood clots that form in the lungs can cause breathing problems on top of the infection that's already going on. Blood clots that form in the brain can cause a stroke. So what we're seeing and doing is, in response to those elevated blood tests that are a marker of clotting, we will start those patients on blood thinners in the hospital, and then also actually after discharge for a period of time, a short period of time, knowing that they are more at risk for blood clots and hoping to minimize the chance that they suffer a clot as a complication of the disease.
All right, thanks very much. Dr. Shaw, I might turn to you on this next one. You mentioned the 8 symptoms to watch for. Could you just briefly go through those for us? Someone had asked about all 8 of them.
Sure. Thanks for the question. Let me share the symptoms and then share a couple of things about the symptoms. So according to CDC, as we learn about this condition, the symptoms have changed, and the symptoms are not when I'm severely infected, but it varies between day 2 and 14 of exposure. Meaning, if I get exposed today, anywhere between day after tomorrow, 2 up to 14 days, I might get some of these symptoms. The symptoms to watch for, the common symptoms to watch for are fever or chills, temperature, that's why the temperature gets checked at businesses, in hospitals, we check for all. Just a simple cough, any shortness of breath, fatigue, just feeling tired, muscle ache, headache, even simple things like loss of taste and smell, which has come up quite significantly. Sore throat comes up, nausea, vomiting, even GI symptoms like diarrhea. So these are the very common, the reason we all worry about COVID and at the time of fall and influenza, that as I mentioned, some of these symptoms also are the symptoms of influenza, common cold. And now we add COVID on top of that in fall, we'll have some of this mixture of symptoms which we hard to know. So the advice for all of us in healthcare and for the businesses is please advise your staff and yourself to get influenza vaccination when it's due in fall, and as many as we can. So that way we at least minimize, not eliminate, but minimize influenza symptoms and signs, and hopefully separate that from COVID.
All right, thank you. The next question, Dr. Carr, and I think I'll turn to you on this one. If an employee has traveled, specifically taken a flight, we are currently considering a 14-day remote work time. Is that necessary, or should they be asked to be tested upon their return? If the test is negative, can they return to work? And within how much time after the return flight should the test be taken?
So there's a lot there to unwrap.
There's a lot there, yes.
So to answer the first question is, the CDC actually just updated their recommendations, I believe in the last 48 hours in regards to travel. So any travel within the domestic US, they're currently not saying that you require any self-quarantine or isolation, just would be like you're going home, monitor for symptoms. International travel, they clearly did not define essential or non-essential workers, but essentially are suggesting that if you've traveled internationally, i.e. whether that's Canada, Mexico, anywhere outside of the US, that you would self-quarantine for 14 days and then return. The challenge, and I believe Dr. Shaw had alluded to this, around testing. So testing is a point in time. So if you have, whether that's an NP swab, NP being nasopharyngeal, or a saliva test completed, that is only saying that there is no RNA detected in that PCR test at that moment. The unfortunate reality is, especially if you're traveling, you have no point to actually know when you were infected. And the sensitivity of the test is highly dependent on when you were infected. So the median is about day 5 to start to display symptoms. And then there's that confidence interval on both sides. It can be as early as 3 days from exposure. It can be as late as 13 days post-exposure. And that's where those 14 days come into. And the unfortunate reality is, let's say I go and get tested after I get off the aircraft. It's only telling me right at that time that I don't have COVID. The challenge is also the false negative rate is much higher when you're asymptomatic and in that pre-symptomatic time frame. The likelihood of the test actually being accurate becomes much higher when the patient is symptomatic. So again, it's very hard to say I'm going to become dependent on the test. They're negative, come back to work, they're fine. Especially when we're talking about international travel, which is a lot harder to control, other things that they're being exposed to. And I suspect that's why the CDC is having such a stringent stance.
Makes sense. The same person asked the question goes on to ask, can you comment on the rotation of 4 days in the office and 10 days out working remotely as a recommendation? I've seen new studies recommending this for business office reentry. Any thoughts?
We can all try to answer this. So the issue with Chris say on this topic about 4 days and 10 days is all depends on the symptoms and see how they are. So if I'm off 4 days, but if I come back on the 5th day and if I have any of these 8 symptoms, 10 symptoms I mentioned, then we need to reevaluate. So yeah, not to keep it as a rigid number, possible good direction if it works out. So what we need to consider, I think the baseline for all of us would become that we'll have to have social distancing in our mind, 6 feet. So in all our conferences room, and I'm sure most businesses, there are markers, there are stickers about 6 feet. So we'll have to keep that in mind. Second, we'll have to advise some form of mask or mask, facial mask, for our staff and our business people who enter our buildings. And then some kind of questioning or screening. So if we keep that in mind, then the duration, whether 4 days or 10 days or 6 and 6, or that might not be as important about that. The rigid numbers probably would not work very well as we move forward.
All right. I think, Clint, I'll turn back to you on this next one. We're considering opening back up if there's a 14-day declining rolling average of the percent of those tested and infections found in the counties in which our employees live and work. Is this the correct parameter or just infections?
So declining percentage of tests turning positive versus just declining number of tests altogether. So let me take the first part. So if you have a declining number of positives altogether, then that's going to be impacted by the number of people you're testing. So if, let's say you were doing 1,000 tests per day and then you all of a sudden do 10,000 tests per day, you're going to see an increase in the number of positives. If you see that the testing rate or the frequency with which you're performing testing is steady, so you're performing 1,000 tests per day, but the number of positives is going down, then that would be indicative that possibly your disease prevalence is going down. That would, to me, would be a more reliable indicator because you've got only one thing changing in that scenario, which is the number of positives relative to the number of tests being performed. That being said, you know, it's really hard and challenging to use that single indicator as the determining factor whether you're going to open up or not. When I think the things that we all look at are kind of more global than that. So it's going to be, you know, from our perspective, we look at how full are the hospitals, what is the hospital system capabilities currently? Are we strained? Are ICUs full? Because those things are important to know. The reason I say this is because most people who have, 80% of people who have COVID will not require hospitalization. So probably what's more important actually when you're looking at reopening is what are the internal capabilities of your business. So if you have the capabilities to perform the physical distancing, to have some of the PPE, to organize your break rooms such that you can get frequent cleaning done, I would use those as more reliable indicators as whether your business is ready to open.
Thank you very much for that. Dr. Shaw, the next question is, can you comment on the value of antibody testing as a measure of safety for returning to workplace? And is there any new prescience of antibodies as an indicator of immunity? And I'm sure I said that right.
This is an important topic, good topic. As we all have heard, quite early in this pandemic, almost late March, something like the immunity passport or immunity card that, hey, we'll check everybody's immunity level. So let me tell some basics and tell the issue currently. As we get new infection in our body, the virus for COVID, our healthy bodies are supposed to produce antibodies towards this new virus, new foreign body. And that antibody we are able to check, including for COVID. And the question then becomes, can we use that as a marker? Unfortunately, what's happened is a lot of test kits came out early in March. CDC was generous enough to let a lot of new companies come up with this antibody checks, not having very thorough, proper check on how good they are. So what's happened, result of that is the antibody levels are not matching with the infection rate. So 3 issues with antibody currently is, first of all, the measurement what we have might not be accurate. Second, the level of antibodies, what the test might give might not be accurate. And then third, the duration. When does my body produce antibodies? So unfortunately, the immunity card, immunity passport, antibody passport is not going to fan out for now. The good news for antibodies, and that's really good news, and Dr. Carrion and Hawthorne can answer this also. If I am exposed to COVID 4 weeks ago, if I'm asymptomatic now, and if I'm healthy, my body is now going to produce antibodies, even though it's not useful for check and coming back. That plasma, we call it the CCP, the convalescent plasma, that plasma is now useful for treatment. And that is being used in all our systems, Unity Point, Mercy, Broadlawns, and many others. And we have seen good results out of that.
Great, thank you. Dr. Carrion, would you like to add anything?
Yeah, I was just going to say, if you don't mind, just kind of me adding to that piece too, even to what Dr. Hawthorne was discussing is, so sometimes it's the optics, right? What do our employees want to see that is objective, that maybe provide them comfort in returning back to the workforce? And unfortunately, what we've seen with social media is we've seen a plethora of increase in epidemiologists across the country, despite what their background may be. Everyone has become a statistician of some sort. But there are multiple different metrics that you can find out there. So a couple that we're using, to Dr. Hawthorne's point about even visitor restrictions. So what objective measures are we looking at? So one, we're looking at multiple, but one of those is the number of infections over a 7-day period per 100,000 lives. So in Polk County, we're at 472 per 100,000. So our goal is to see that number under 100 before we lift our visitor restrictions. The other is this value known as the R0 or RT value that we're following. That RT value tells us how infectious is COVID-19 right now in our community. And if that number is greater than 1, then that prevalence is still high. And unfortunately, as we know with statistics, that confidence interval plays a role. So although today our number is 0.91, that confidence interval is still greater than 1. So the likelihood of community transmission is still there. So as long as those two numbers suggest that, we are kind of avoiding lifting those visitor restrictions at this point. To Dr. Shaw's comments, which were right on point in regards to antibody testing, this has been a very common question. So not only are the tests potentially inaccurate, just because, again, there's been such a push to get testing out there. The other challenge is what we don't know, and what these tests are predicated on, is prevalence. So the more prevalent an illness is in your community or county, the higher positive predictive value that test has. So what that means is if I get that test done and our prevalence is under 5%, and the CDC does a great explanation if you want to go to that website and look for antibody testing, it says if the prevalence in your community is 5% and you get tested, there's a 50% chance that that test is right, and there's a 50% chance that test is wrong. So essentially, it provides limited value. Back to Dr. Shaw points, where we do see is in clinical context, right? So if we believe you have tested positive, and now I want to use your plasma for the treatment of a patient with COVID-19, that's where the test is highly sensitive. Or in situations where maybe the clinical setting is suggesting this patient is positive, but maybe it's not matching up with the results that we're finding. Again, those are the other settings where we're finding some degree of value in those tests.
All right, thank you very much. Dr. Hawthorne, a question on screening. We heard a lot already about screening workers coming in and out of the building. Could you maybe comment on what the process would look like, what type of screening, what frequency of screening, what is a good baseline practice or basic practice for all businesses to consider when it comes to screening their own employees?
Yeah, so I guess I would emphasize the 8 symptoms that Dr. Shaw just relayed to us. So having employees be aware of those 8 symptoms so that they can track their personal symptoms. One kind of really objective way to do that is just have them keep a log, and they can see it, back the last few days, what their symptoms have been, if any. For most people, they're going to have no symptoms. And so then you start to go into the question of, taking temperatures. And so there's probably some value in temperatures. The optics of it are certainly a part of that, I'll be honest, because it's just a good reminder of what we're trying to do, trying to be aware and self-aware of our symptoms. And then really, I think the next step to that is, so what if someone starts to develop some symptoms, because they're, what do you do with that? And so at that point, that patient needs to be self-isolated and then referred to determine what their risk factors are in testing. And so you can work with whoever you work with through employee health matters to get that accomplished. But really, it's pretty straightforward. I guess it's tracking the symptoms, and then you can have people do that in an objective fashion.
Okay. And maybe as a carry on to that, maybe I'd like to kind of hear from everybody on this is face masks in the office. This is a question I hear all the time. It's one I think of myself. What are your thoughts on face masks?
So I can take that first if that's okay. So I think you're absolutely right. It's a little bit of all over the place with what should be the appropriate attire for use and the value of face masks. So as we know with face mask, the goal there is to minimize your transmission to someone else. So that's first off. So it's not your decreasing of acquisition of the illness, it's your ability to minimize your infection to someone else. The second piece is what we find is people just don't use it very effectively in the lay public. You can walk around and you'll see it, kind of up over their head or under their chin, and they, depending again on the activity that you're requiring to do, they can actually feel slightly, impede your ability to breathe. I mean, I notice I get pretty hot and I have to move it because I can get a little bit short of breath. And really one of the challenges, and there was a study that was done out in Wales, is we touch our face like 23 times an hour. And so one of the challenges, if this is a droplet transmitted condition, which everything is kind of pointing in that direction, is we want you not to touch your nose. We don't want you to touch your eyes, and we don't want you to touch your mouth. So when you're pulling those masks down kind of repetitively, you're potentially increasing your risk of touching those areas. So you could be putting yourself in harm's way. So I think one of the important things, and I believe this is actually required through IDPH, is if you're going to make that request of your employees, is educate them on the appropriate use of those face masks, ensuring that they understand. And one of my infection preventions use this term, avoid men, right? Avoid mouth, eyes, and your nose, and which I think is a very easy mnemonic to remember, and something that we have to be conscientious of. Now, there is a push, and I'm sure you've seen the editorials from a couple of the infectious disease physicians from the University of Iowa that have suggested face shields. Now, the beauty of face shields is it actually does provide a little bit more protection than face mask, because it's now covering your eyes. You have a decreased ability to touch your nose. And the most important piece, what I like about face shields, is I can actually see your facial expressions, right? Because part of a lot of communication, especially if we're in office or, again, taking orders, whatever it may be, the face shield provides the ability to still communicate and not lose that piece of our communication. So
I agree with Dr. Hinyo. The only last point I would say that I like face masks, because when I wear it, I can swear at the person or mumble myself or talk to myself and nobody would know. No, no, I agree with, I know, no, joke apart, the facials probably will make sense also, yes.
Yeah, no, I agree with that. And that's going to be something that will probably need to be normalized in the future. I mean, face masks have started to normalize. Face shields would be probably a better protector, as you're talking about, Dr. Carion, but there's going to be a normalization of that will definitely take some time.
Yeah. The latest question that came in, can you comment on how hospitals continue to mitigate the entry into institutions with respect to staff, visitors, and non-essential people? PPE, temperature, minimize the number of people in the buildings. What indicators are you looking for to elevate these restrictions? I think you may have answered part of this earlier, but maybe just Dr. Hawthorne, can you just talk about what your hospital is doing right now as far as limiting people coming in and out?
Yeah, Dr. Carrion touched on a lot of this, and I'll just, I guess, give the current essential visitor policy, which is there's no visitors allowed within the hospital, with some very few exceptions that have to do with patients who are actively dying, pediatric patients. And then in the emergency departments, we do allow one visitor with the patient, because the dynamic nature of the emergency department, we're in an information gathering point in their patient care. There's just a lot of moving pieces where visitors actually play a really important role in the ability to care for that patient effectively. So that's why we do allow them in the emergency department. But yeah, I'll defer to Dr. Carrion about the metrics that they're tracking at a system level, because those are really objective data points that can be used to start to guide overall system level decisions on visitor policies.
Dr. Carrion?
So as I think I stated a little bit ago, is the two metrics that we're following pretty closely is the number of cases per 100,000 in Polk County and the RT value. And again, that RT value, what we know about is as long as that number is greater than 1, that means there's ongoing community spread and the risk of community spread is high. So those are the two objective measures that we're using to guide visitor restrictions. So the other comments that you made around medical students, other non-essential workers, whether that's, again, interviewees, interview candidates, visitors, other pieces, all kind of combine into those when we decide to kind of lighten up our restrictions. So we're really trying to mitigate, again, non-essential workers within the hospital to minimize, again, the potential for spread. So those are ongoing discussions that we continue to have with Dr. Hawthorne, CMO at Unity Point, Dr. Pirtle, Dr. Shaw, and other leaders across our metro to decide how we start reinstituting those processes as we do that, because we also want to be conscientious of our PPE, because unfortunately, from a state perspective, we don't have unlimited PPE, so we need to be very conscientious of that.
I think that last part that you mentioned is really important. I just want to emphasize, those are decisions that are made not just at the Unity Point level or the Mercy One or Broadline. Those are or those are decisions that are made together so that there's consistency.
Great. So going back to this mask versus shield, and that's something I hadn't thought of. If you require everybody to wear a shield, do they need a mask?
So my personal opinion is no, they don't need a mask. And I'll tell you that we have instituted this in our psychiatric areas where we really believe that again, being able to see the provider's face becomes much more important, again, depending on the behavioral health condition that's exacerbated. And so we're only having them use face shields.
All right.
And if you go back to the reason for a mask, as Dr. Carion mentioned, a mask, if you're asymptomatic, is to prevent the possible transmission to someone else.
Yeah, makes sense. So Christy asks, is there a concrete definition of an exposure? Is there a certain amount of time a person needed to spend with someone? Do they need to be closer than 6 feet and within a certain number of days of their positive test? This has got to be complex.
Yeah, no, it's a complex, but it's a good question. And that also leads into contact tracing concept, which we probably for businesses and for community, for public health, we need to talk about. So the numbers, Chrissy, are within 6 feet. If I'm symptomatic, if I'm within 6 feet for more than 15 minutes, then the chances of my virus, my droplets coming on the next person is higher, and that person would carry that. So yeah, 6 feet, 15 minutes or more, and the symptoms would then have to watch for 48 hours or more after that. So that's a same concept we need to take forward in contact tracing for hospitals and business. That if my staff is now positive, we'll have to go back and think about that. Okay, how many staff, people, customers did this person come across within 6 feet for more than 15 minutes, 2 days prior to becoming symptomatic and few days prior to getting the symptoms. And that's the contact tracing point, which we all need to do much better. There are hopefully going to be some softwares available about this topic, about this contact tracing, which we'll have to use and do the contact tracing.
All right. Dr. Carrion, I think you mentioned limited PPE supply. Someone asked, what is the supply? How are the current supplies doing for all of you and for the state?
I think from a metro perspective, we're actually all doing very well. So we've been very fortunate that, again, early on, all the metro hospitals and physician leaders kind of came together to say, you know, how do we work together to facilitate, to ensure that we have the PPE supplies that we need. We actually most recently met with Governor Reynolds just to talk about can we allocate at the MCC level, so at the local metro level, and determine if there is a need at one of our facilities and delegate that PPE out if we feel, one, that they're judiciously using the PPE, and she kind of agreed with that decision. So that's what we'll be doing kind of moving forward, is being able to locally distribute it. Now, the interesting piece is we all have different supply chain that we use for replenishment of PPE. So it was slightly comical to know that each of our individual entities were struggling to get different products. We had plenty here, but just struggling to get, I believe Unity Point was having issues with bouffants. We were having issues with shoe covers. And I forget what broadlawn shortage was. So it was just interesting that it was actually different pieces of equipment. So.
Interesting. The next question is, maybe we'll go to Dr. Shaw for this. The new World Health Organization guidance for face masks recommends that adults over 60 who are in communities or regions experiencing community spread should wear surgical masks in public. Will we be able to reach a point where citizens outside of the healthcare or first responder situations have access to these kinds of masks?
So yeah, Susan, that's a good point. The question then for the mask is there are 3 different layers of mask. One is the fabric mask, which we all have talked about, and I'll describe that in detail. Second, being better than fabric masks, the surgical masks. And then third, what the few healthcare providers use is this respirator mask, or the N95, what it goes by. They're also equivalent to other numbers called 8210. So back to that question, is surgical mask better than fabric mask? Yes, there is a, so the concept depends on whether it's a woven material or non-woven. And non-woven are the surgical mask where if I'm the carrier, my particles don't come out, or if I'm wearing it, I don't get somebody else's particle in my system. If the fabric mask is done with the 4 layers or more, the studies show that more the layers, the less the possibility of that virus to go into my system. So yes, we either need a high quality 4 layers or more fabric mask or surgical mask if you are a high risk patient, 60 and older, or carrying symptoms, COPD or others. If you can get surgical mask that is higher level of protection, the reason we didn't come out with CDC because there was and there is shortage of surgical mask for everybody.
Right, right. Okay, it looks like we have another question here on mask versus shield. For additional clarification, does a face shield limit possible transmission to others, or is that only with a mask?
The face shield would limit, if I'm wearing the face shield, then if I'm coughing, then that cough would not come within 6 feet to my cube. So that, yeah, no, it would protect. The question then becomes, is it proper enough, long enough, so the particles don't come out from below and then hit? Yeah, so that those all will come depending on what kind of face shield we are using. Just like mask, it's not just one, each mask is same. No, there are different levels of mask.
Sure. Dr. Carion, what about common areas such as conference rooms, break rooms, especially kitchens, things like that? What kinds of recommendations do you think the businesses should be looking at for those areas?
So as far as having those, I still think there is value in having those areas. I think some people have asked previously, not today, about closing those areas down and not having common areas. I think, again, as long as you're able to provide the physical distance and as long as you're able to disinfect those areas after use are extremely important. So I think those are the two things. If you're able to maintain a cleansing environment, I would encourage having those common areas still, because again, there's typically value there if that's where your employees may eat, or again, where they may convene for a short period of time. The things that I would discourage are using anything that would require maybe common spoons that may not get sanitized. I would highly discourage those where, historically maybe people had potlucks or those things in the workplace. Those are the things that we would discourage. If we have food or fruit that are out, we do individually wrap each of those products to, again, ensure that the actual content is protected.
Makes sense. So one of the big questions we're hearing, and I guess I'd kind of like to hear from maybe many of you doctors on this, is what about school in the fall? And the reason this comes up is not only for the reasons that a lot of us who have children, thankfully mine's an adult, but it's a really big impact on the businesses. Obviously, the stress that this is putting on parents trying to provide schooling to their children is also providing stress into the business. So any guidance on what it looks like as far as children returning to the classroom this fall? You want to start out, Dr. Carrion? Put you on the spot?
Sure. So I think this is a very hot topic, and I've had a couple discussions over the last few weeks just in what schools are talking about. Because I do think, again, from a child care standpoint, it is very challenging. In addition to the reality is there is multiple different economic impacts that the school provides for some of these kids that are in environments that maybe our children are not, unfortunately are not. So some of the discussions are still providing an environment of physical distancing, which I think is important for those that want to be protected in that position. Some thoughts, and again, this is just thoughts that I've heard, is potentially allowing those children that are older in age to be those virtual learners and creating those environments and transforming them into schools where you can now accommodate some of those elementary or middle school age to, again, provide those environments where it's a smaller classroom and not impact the overall duration of the day. Because I think the other challenges where I hear about every other day or half days, again, if you're an employed person, that's really challenging to navigate pickup, drop off, daycare for those afternoon times, especially, again, if your employer is expecting you to be there from a defined period of time.
Dr. Hawthorne, anything you'd like to add?
Yeah, I don't have any special context or insights into exactly what is being planned. I know that there will certainly be measures that are put into place that will probably focus on physical distancing. We'll also probably look at the possibility of having more offsite learning opportunities for our students. What that balance will be, I don't know. And I agree with Dr. Carr. I mean, it's a challenging issue because you have folks who are trying to manage their work from home environment now with students, their children who are doing school from home, and what that exactly will look like. I don't know. I do know that the superintendents from around the state gathered together and are looking at the options and are being led by the governor. And so there's definitely going to be, it looks like some general guidelines that they can follow. Obviously, there's not a one size fits all for all schools, but at the same time, they're going to try to have some uniformity to it.
Sounds great. Well, I think we've kind of depleted the questions we have. And Dr. Shaw, I know you need to leave just a few minutes early. I guess I just ask each one of you, and Dr. Shaw, if you'd like to start, just any final comments you have before we wrap up the session.
So yes, thank you again. And that's what pandemic is, that this is going to be new normal, which the term we have used many times and heard many times. But now we'll have to live with it. And then each of us, each institution, each business will have to decide what is our new normal and getting used to that. The second topic comes up frequently is, do we expect the surge? And if so, when and how big? That will again depend on many factors, including how fast we start opening up and how don't, and how much social distancing and masks or face shield we all decide to use. Thank you.
Thank you, Dr. Shaw. Dr. Carion, do you have any final comments for us?
Yeah, I would just like to echo what Dr. Shaw said and say thank you for the invitation. I know everyone has their work cut out for them as they start exploring bringing their employees back. And again, just ask for empathy for each of your employees during this time, because it's been challenging in so many different aspects, not just COVID-19, but obviously the recent gatherings and riots that have been occurring kind of across our country as well. So I know the other piece, again, as we talk about physical versus social distancing being even more valuable to ensure that you are ensuring your employees are getting that potential support that they may need, especially since they may not be face-to-face as they normally have been. The other pieces that people are asking are around those riots or gatherings that are occurring kind of across our country. Will we see an increase in surge? Now, I will say, and again, this is anecdotal, what I've been pleasantly surprised about is that a greater majority of these individuals have been wearing face masks. One of the things that is key is also ventilation. So the fact that these gatherings are outside also minimizes the potential spread. And again, as Dr. Shaw had alluded to, the 15-minute duration of close contact is really where that increased risk of conversion occurs. So in these outside warm environments, not prolonged interactions, the likelihood is we may not see a huge surge despite these gatherings that are occurring kind of across the country. And then my last request is just for grace, because I know with all the changes that have occurred with COVID-19 and some of the hysteria associated with it, this has been one of the most fluid conditions that we've had to deal with, at least in our lifetime. And recommendations have changed from one day to the next, from 1 week to the next. And so anything that we say now may potentially be debunked, but at least this is based off the best recommendations and science that's currently available to us.
Thank you. Dr. Hawthorne, we'd all like to stay out of your emergency room. What are your thoughts?
Yeah, I love what you said, Hino, about just allowing for grace. This is a novel coronavirus, and I think I would put the emphasis on the novel part. And so you've seen all the things that we have learned over the last 3.5, 4 months. That learning is continuing. That learning will continue for quite a while. And so you'll see changes to recommendations. You'll see new ways of going about how to physical distance, how to keep people safe, how to mitigate transmission, and the required flexibility around that is huge. And so I appreciate working with all these folks here, but I appreciate your businesses and how they've really taken keen interest in how they can keep their employees safe. And so kudos to you for doing that and signing on to be with us today. And I just go back to the idea that as you look at different things that you can implement, it's oftentimes the simplest things that are most effective. And the reason that they're most effective is because they have a high compliance. And so if you can work on those simple things, and we've touched on a lot of them here, I think that that's a great start.
Well, I want to thank you all for joining us, and thank you to the people who signed in as well. As a final reminder, if you have further questions, reach out. DSMpartnership.com/DSM forward is a good resource. And with that, I want to let these gentlemen get back to their regular jobs. Thank you so much for your time. We know how busy you all are.